I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about hormone therapy and menopause and who's a candidate, who's not a candidate. Does it benefit you? Does it not? And we're going to be going over all the things today. Of course, a few things that I always make clear is this is not meant to be any type of medical advice. If you have any questions about midlife health, make sure you go check it, speak with your healthcare provider. And if you have any questions about your religion, make sure you go ask your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. Okay, so let's get into it. Today, I'm going to be talking about menopause and what exactly is that. And then I'm going to be talking about hormones and, who's a candidate, who's not a candidate, the timing hypothesis, all that great stuff. Okay, so let's get into it. First thing I want to just talk about, just basics. I'm sure, those that are listening or watching know enough about menopause to know that menopause is the event in a woman's life where she goes a whole year without a period, right? And so the time before is considered perimenopause. And that can last for, depending on your ethnicity, it can last about 10 years. It can last for African-American women, it lasts about 10 years. And we know this because of the SWAN study. And for Hispanic women, it can last about 8.9 years. For Caucasian women, it's about 7 years. For Asian women, it's about 4.5 to 5 years. And for South Asians, it's about 8 to 9 years. The reason why that's important is because if we think about what the mean age for somebody that goes through menopause is, it's about 51 here in the US. And so if you were to subtract 9 years or 10 years, you would know around the time that you start to go through perimenopause. And as you know, perimenopause is a time where we have all these symptoms of, it could be hot flashes, night sweats, but that's not the only thing. Some women never even get those. It could be vaginal dryness. It could be pain with sex. It could be decreased lubrication. It could be joint pain. It could be dry eyes. For some women, it's vertigo. For some women, it's heart palpitations. For some women, their biggest problem is brain fog. So there's a lot of symptoms that can start out in perimenopause that we don't often put together, right? So a lot of times women will be having all these constellation of symptoms and they won't know, what's going on. In fact, I just had a woman that called me last week in my office and she said, I find that my mood is changing and, I'm starting to have this unexplained rage. I'm not really sure where that's coming from. I feel like I'm not acting like myself. I'm having this new onset anxiety and depression. And she's like, I'm wondering if I could be in perimenopause. And I was telling her that absolutely, you could definitely be in perimenopause. We also know that women that never had anxiety or depression a third of women will develop new onset anxiety and depression. And that's because there's a lot of estrogen receptors. We know we have estrogen receptors from our head to our toes. And so there's estrogen receptors everywhere. And that's why it's important to know around what time you may be experiencing these symptoms, because then if you have them and somebody says, no, there's no way you could be in perimenopause, you can tell them that, no, I know that through the SWAN study, we know that different ethnicities, go through perimenopause for different lengths of time. So that's why I bring that up. Okay, so now let's get into what exactly is menopause. So we know that menopause is essentially estrogen deficiency, right? And we know that estrogen is this systemic regulatory hormone that has widespread receptors throughout our body, right? So there's estrogen receptors throughout the brain, the bone, cardiovascular system, bladder, vagina, connective tissue, which explains why so many women have so many different symptoms, right? And a lot of women have different symptoms, but a lot of women have the same symptoms. So it's because there's receptors everywhere. Menopause, we know, is essentially estrogen deficiency, and that's why we have all these symptoms, including the hot flashes, the night sweats, the neurotransmitter imbalance, our sleep changes, right? Bone metabolism changes, collagen support changes. Women will find that they have, like, all these new wrinkles that they never had before. Maybe their hands look like they've aged more than the rest of their body, right? So just really interesting, all the different things that happen. And because of the widespread distribution of estrogen receptors, we know that it is not only the reproductive tissues that estrogen exerts an effect on, but also cardiovascular function, right? It includes arterial dilation, and estrogen also protects the heart. It also helps with bone metabolism, maintaining bone density. It helps with neuroprotection and mood regulation and connective tissue. So, that being said, we know that systemic estrogen therapy reduces hot flashes and night sweats by about 75%. And that's really important because what happens is that sometimes patients are really afraid to go on estrogen therapy. And so they'll go to their doctors and they'll say to them, I don't want to go on hormones, but I need something for my hot flashes and night sweats. And so the doctor will give them the non-hormonal treatments for hot flashes and night sweats. And that could be, we have those medications, two medications that act at the level of the brain, at the KNDy receptors. We also have used SSRIs and SNRIs and gabapentin to help with the hot flashes, but we know systemic estrogen therapy reduces hot flashes and night sweats by about 75%, compared to 40 to 65% reduction with the non-hormonal alternatives of SSRIs, SNRIs, and gabapentin. And it's also important to know that when, estrogen levels drop, either with surgical menopause, premature menopause, or early menopause, the body feels a little bit destabilized, right? So the thermoregulation, which is what we just talked about, the hot flashes and night sweats, everything starts to change a little bit. And when we use hormone therapy, when it's used appropriately in the right patient population, it's essentially replacing what the body can no longer produce, right? But it's not in a super high level, right? You're not going to get like some super physiologic levels of estrogen when you take the FDA recommended amount, right? We're not doing pellets. We're going to give you what is approved by the FDA. So basically, what that does when we give you hormones, it stabilizes the symptoms and protects and gives you some long-term protection, and your quality of life improves as well, right? So the North American Menopause Society put out a statement in 2022 that stated that hormone therapy remained the most effective treatment for hot flashes and night sweats, and for the gender urinary syndrome of menopause. And we're going to talk a little bit about what that is as well. But if you've seen my other podcasts, you know that I've talked about that before. And we know that the guidelines came out via the AUA, the American Urologic Association, earlier this year, where they talked about the gender urinary syndrome of menopause. Okay. So now let's talk a little bit about the timing hypothesis. What is this? I don't know if you've heard of it before, but basically what it states is that hormone therapy is best, you get the most effects, right? Like you'll get the most benefit from hormones if they are started within 10 years of menopause or before the age of 60. Now, does that mean that somebody that's in their 60s cannot get hormones? No, absolutely not. That's not what that means. Because say that somebody got, and did their periods when they were 55, if they're, even by the age of 65, right, they still have that 10-year window to start using hormones to gain the most benefits. Now, what if you're out of that 10-year range? Then what happens is that you need to go to your provider, and they would go over the risks and the benefits. They'd probably also take a look at your cardiovascular risk and look at if you were somebody that had a high risk profile, a low risk, or medium risk, right? Based on the American Heart Association. They stratify individuals based on their risk factors, and they would help you to decide whether or not hormones were right for you, right? So being within 10 years of menopause is really important because that's where the research has shown that you get more benefits than there are risks for starting hormone therapy. But again, like I stated, if you are more than 10 years out, then definitely go and have that conversation with your own doctor. And this is because it has the most favorable benefit risk profile. And we know this, the timing hypothesis is what I'm talking about right now, based on multiple analyses, including follow up studies beyond the WHI era and those published in Menopause and JAMA. And those findings also support the timing hypothesis. It states that the cardiovascular risk associated with hormone therapy appears to depend on the beginning of starting hormone therapy in relation to menopause onset. Okay. And this hypothesis came about by they basically removed the ovaries of primates. And then they gave them conjugated equine estrogen. And they noted that in those animals, the conjugated equine estrogen, or the estrogen, right? And that's the synthetic estrogen, prevented atherosclerosis only in animals treated early after surgically induced menopause and before the onset of atherosclerosis. So they noted that the most amount of benefit was in those individuals that had no disease, right? Or really little disease of atherosclerosis before. So the most amount of benefit that you get is when you start hormones early on, right? Before the onset of atherosclerosis. Once the atherosclerosis is set in, then you don't get as much benefit. And also, what they noted in women who started hormone therapy earlier, there's a reduced risk of a coronary artery disease, right? For estrogen alone, which was again demonstrated in several studies, including the meta analysis done by Salpeter and trials like the ELITE trial and the KEEPS trial, which found reduced atherosclerosis in younger, recently menopausal women, as opposed to those women that were older, where the risks might not be offset. So this is something that's really, really important. And I want you to remember this for those of you that are considering hormones. And again, if you are beyond this time frame, doesn't mean you can't have it. You just need to have a discussion with your doctor. They take a look at your risk factors. I'm sure they'd probably ask you to, check your cholesterol, check your cholesterol profile, your triglycerides. They would check your HDL, LDL, all of that stuff. They'd probably also have you get a calcium score to see if there's atherosclerosis that's already started in your coronary arteries. And then, you probably make a decision based on that. So that's between you and your doctor. So when initiating hormone therapy within 10 years of menopause or before the age of 60, they also noted that there was reduced all-cause mortality and coronary heart disease risk. And so that was super important. Also, from the WHI study, we know that, so remember, we get a lot of our information from the WHI study. It was one of the best conducted studies. It was, I would say, actually, it was rather the most, it was the most highly funded study ever for women's health. And so we got a lot of information from that study. And from that study, we know that conjugated equine estrogen alone decreased breast cancer risk by 23% while reducing breast cancer death by 40%. And the problem with the WHI study, though, that we know now and that we've seen after it's been about, like 23 years since that study came out, is that the reason the WHI traumatized basically a whole entire generation is because it included women that were well beyond that menopausal transition. So the mean age for somebody in that WHI study that, a lot of people still quote today that say that cause that fear of estrogen causing breast cancer is that we know that the women in that study were, the mean age was 63. So if we think about, the mean age being 51 here in the US for somebody that goes through menopause, that was well beyond the age, and it was well beyond the 10-year age frame, right? That time frame that we give for the most benefit that we know based on the studies that I had mentioned that women get from hormones. So with this, right, in those women, the vascular disease was already well established. And so, they didn't find a benefit, a cardiac benefit to initiating hormones later on for women. In 2023, multiple review papers reiterated basically the timing hypothesis, including a commentary in JAMA and an updated clinical context piece in the Menopause Journal. The timing mattered not just clinically, but also biologically. So, when we have these conversations with our doctors and you as a patient or somebody that's really interested, you really have to individualize care. You have to take a look at what patients' risk factors are to see whether or not they are a candidate. So, what does HRT, right? What HRT actually offers as a benefit? So, what are the benefits of going on HRT? Or rather, now we call it menopausal hormonal therapy, right? So, what are the benefits? So, we know that it is the most effective option for hot flashes and night sweats. We know that it improves sleep when sleep is disrupted by hot flashes and night sweats, right? So, if you're not having those hot flashes and night sweats, you're going to definitely sleep better. It prevents bone loss and reduces fracture risk. It improves the genitourinary syndrome of menopause, which is, that dryness, that burning, that painful sex, that decreased lubrication, the overactive bladder. It helps to maintain that normal pH of the vagina. It helps to normalize the vaginal microbiome, right? So it's super, super important. And most individuals, even if they decide that they don't ever want to do systemic therapy, we know that vaginal estrogen is super safe. There is some absorption into the body, but it keeps the estrogen level within that postmenopausal range, and it does not increase estrogen levels. So for those individuals that want to take, vaginal estrogen, but are concerned about the systemic estrogen, you don't have to worry. The only people that, I believe that it's contraindicated in is somebody that's had a leiomyosarcoma, which is super, super rare. It's like a cancer of the uterus. And it's where, all of a sudden that uterus starts to grow really big, and it can be very devastating. But anyways, that is super rare and it does not happen very often. We don't see that very often in individuals. And so for the most part, most women can take vaginal estrogen. We also see that estrogen may reduce the risk of developing type 2 diabetes in some women. And this has been noted in several reviews. It can support cognition indirectly by improving sleep, mood, and the hot flashes and night sweats. And of course, we know that the brain functions better without constant physiologic stress. Okay. So are these, will I or can anyone really guarantee that these things are going to happen or that you'll get these benefits? No, of course not. You can't guarantee anything in medicine, but we do have a lot of data and support saying that estrogen does do all of this stuff. So why personalization matters? Well, we know that not all, right? So no one size fits all. We know that some women want and desire to have systemic estrogen, other women don't. Some women will need micronized progesterone or progestin, right? A progestogen, some form of progestin that when they still have a uterus, we want to make sure that we always offer that to women because we know that unopposed estrogen can lead to endometrial cancer. So obviously we would definitely want to prevent that. We also know that some women may need, testosterone off label for low libido, right? And so we have guidelines for that. And we know that some women, and a lot of women in my practice, need a combination therapy. They need that. They need all of the hormones. They need the estrogen. They need the progesterone. They need the testosterone, right? And so it's important to know that dosage matters, route matters, and formulation matters. We also know that this is what's called precision medicine, right? This is measured. This is evidence-driven dosing and monitoring. So now let's go a little bit into breast cancer and why that's been the number one fear for women who want to start hormones, right? And I still hear this. I hear this all the time, actually, to be honest. I hear this all the time from women that are really they may not know that much about menopause, about perimenopause. They're still learning. They don't understand. And so all they see and all they hear is the fear of estrogen causing breast cancer, and they hear it from their friends. And so they're just really not sure what to believe, right? So here we're going to talk about estrogen and progesterone therapy versus estrogen alone. We're going to talk about the breast cancer risk difference between combination and estrogen alone therapy, why hysterectomy population risk profile is different, and why local vaginal estrogen is not the same thing as systemic hormones, right? We know that. We talked a little bit about that right now. So let's get into it. So breast cancer, cardiovascular risk, estrogen versus combined therapy, and local versus systemic therapy. So now breast cancer fear, right? So let's talk a little bit about that. One of the biggest things, like I just mentioned, that prevents women from taking hormones is they are fearful and they are afraid that the hormones that they take, the estrogen that they take, is going to cause breast cancer. And this fear came about from the Women's Health Initiative, from that research, that study that we talked about in 2002, right? So the headlines, what most of the headlines never highlighted clearly was that in the arm where women received estrogen alone, and these were women that had had a hysterectomy, right? So they have no uterus. There was no increased risk, or actually, rather, there was no increase in breast cancer risk. In fact, some analyses showed a reduction in breast cancer risk. Okay, so that is something that we never saw in the headlines. We never knew. And actually, I'll tell you that the doctors that I trained with, and I love them, and I loved my residency program. I thought it was fantastic. But I will say that, the doctors there never made a distinction. And that's probably because they didn't know, right? And they weren't told, and they just believed what the headline said. And so that's what they told us in residency. But in the arm where women received estrogen and medroxyprogesterone acetate, so at that time, right, the study was done on women that took this conjugated equine estrogen. So that was the estrogen alone arm. Then there was an arm of the study that took estrogen and progesterone. It was the medroxyprogesterone acetate. And then there was an arm that didn't take any hormones. And then so the arm that had that synthetic progestin, that is where there was an increased risk signal. And some people, say perhaps it wasn't statistically significant, but regardless, that was a side of the arm of the study where they noted that there was an absolute risk increase that was approximately 8 in 10,000 women per year that were attributed to combined hormones. Okay, so we saw a slight increased risk in the arm that had the estrogen and the progestin, which was that medroxyprogesterone acetate. It was not in the arm that had only the estrogen alone. So, that's why this is really important, because we know that estrogen alone and estrogen and progestin are two different categories, right, of therapy. ACOG, North American Menopause Society, now it's called menopausesociety.org, and follow-up analyses also reiterate that risk is formulation dependent and timing dependent. And when women say that, hormones cause breast cancer, we know that that's not accurate. And it's really important to know what they're referring to, right? So we know that not all hormone therapy. And hormone therapy, the one that we use, I'll tell you. So at that time, right, they used this progestin, which is that medroxyprogesterone acetate. And that's the one that they think perhaps may have increased. And they said the absolute risk was increased. And they had 8 in 10,000 women that had a risk of developing breast cancer. Okay. We don't really use that progestin anymore. In fact, in my office, I use micronized progesterone. So micronized progesterone is the quote unquote bioidentical progesterone that our body makes. And there have not been any studies. I think that somebody says that perhaps, I think there were like 5 randomized control studies that had estradiol with this progesterone, this micronized progesterone, and they saw no effect essentially in that micronized progesterone, like a null effect in causing or increasing breast cancer risk. So that's really important to know and understand. But remember that data and studies are very limited. And so, we can only say what we know. And there aren't that many studies available on micronized progesterone and estradiol. So the route also matters. We know that transdermal, so we know that's something that goes through the skin, right? Whether that's patches, whether that's gels, estradiol sprays, whether that's a ring, that all bypasses the liver metabolism. And this is associated with a lower blood clot risk, right? So anything that goes to the skin, because it is not going through the liver, it doesn't activate the clotting cascade that the liver can activate. And because we're going through the skin, that doesn't happen. And so there is a decreased risk of blood clots with transdermal estrogen. Let's talk a little bit about the vaginal estrogen. I'm not going to belabor this point because I feel like we've covered it a few times, but again, really important to know that local vaginal estrogen is very different from systemic estrogen. It is highly, highly effective. Almost, I would say it is the gold standard for the genital urinary syndrome of menopause, because what is it going to do? It's going to help to rebuild that tissue. I mean, absolutely, you can use non-hormonal therapies, right? You can use a vaginal moisturizer, but a vaginal moisturizer what is that going to do? It's going to, if it's made with hyaluronic acid, it's going to plump up that tissue, but it's not going to do all of the things that vaginal estrogen will do, it'll decrease overactive bladder. It's going to increase lubrication. It's going to decrease pain with sex. It's going to normalize the vaginal microbiome. It's going to improve the vaginal pH. It's going to help recruit blood vessels to the vulva. And this is something that a vaginal moisturizer cannot do, right? So it's really, really important that even if you decide you never ever want to do hormones, that it's not right for you for whatever reason, whatever, perhaps based on your history, that for the most part, for most women, they can take vaginal estrogen. And that is really important. Now, let's talk a little bit about cardiovascular risk, okay? And cardiovascular, there's a lot of nuance with cardiovascular, I would say, like risks and hormones. So this is where this is really, really important, right? To take a look at your patient's history, to take a look at what their risk factors are. So let's talk a little bit about that. We know that cardiovascular disease is the leading number one cause of death of women, okay? And women present differently that are having a heart attack as opposed to the way that men present. We know that estrogen withdrawal impacts vascular stiffness, right? So basically, what does that mean? It means like our arteries, right? Whether or not they are pliable, meaning like they can expand, or they become stiffer. And we know that when estrogen goes down, our arteries can become stiffer. It also estrogen affects the lipid profiles, it affects metabolic parameters. And we know that starting hormone therapy early within that window that we talked about before, that timing hypothesis, is associated with either a neutral or potentially favorable cardiovascular effect in some women. And this is super important. And this is supported across multiple reviews and reinforced in the Menopause Society guidance and in several cardiology endorsed position statements. We know that starting late after atherosclerosis is established is where we see the risk elevation. And again, timing matters more than absolute. So this is why individualized evaluation, shared decision making make a huge difference, right? Because you want to make sure that are hormones going to be right for me? Do I have an increased risk of cardiac disease? Is there already plaque buildup in my arteries? And if there is, what is the risk there? We know that if there's already plaque buildup, right? And if we start estrogen, there's a thought that estrogen could, within like that 1 month, window could destabilize a plaque that's already there. However, if you take a statin, and it actually helps to stabilize that plaque. Okay. So really important to know what your cardiac risk factors are to see if, you already have heart disease, whether or not you don't. Hormone replacement therapy, really important. Okay. So this is a key point, and I want you to remember, because I don't want you to go, after you listen to this podcast and say, oh, we give hormones to prevent cardiac disease. That's not it. And it's not recommended for heart health or cardiovascular disease prevention in postmenopausal women. Okay, so the current clinical guidelines, practice guidelines, the current clinical practice guidelines recommend against using hormone therapy for primary or secondary prevention of coronary heart disease, right? So we can't say that we're going to give hormones to prevent cardiac disease. However, when initiated, right? So when hormones are initiated in women younger than 60 years of age or within 10 years of menopause, hormone therapy can actually reduce heart disease risk by approximately 50%. And all-cause mortality by 30%. Okay, so a recent analysis from the WHI's initiative found that among women aged 50 to 59, and so again, here is where that timing matters, right? This is why we kind of focus on that and we kind of talk about that a lot, because a lot of information that we have gotten since the WHI study shows that the most benefit that women get is if hormones are started early. Okay, so a recent analysis from that WHI study showed that women aged 50 to 59 years with hot flashes symptoms, and if they used hormones, so if they used that conjugated equine estrogen, or if they used that conjugated equine estrogen plus the medroxyprogesterone acetate, had neutral effects on atherosclerotic cardiovascular disease, meaning like there was no effect on it. Okay. And that was with those old medications that the WHI study had shown, right? So they took a look at that subset of women that were within that range of 50 to 59, and they wanted to see when they had used those medications, those hormones, did that affect their heart, right? And they noticed a null effect, a neutral effects. So in contrast, women starting in that same study, right, in that WHI study, in contrast, women starting therapy more than 10 years after menopause or after age 60 showed no cardiovascular benefit and faced an increased risk of stroke and blood clots. Okay, so that was from that WHI study. But remember, right, if you are within that age frame, it looks like it may reduce, so hormone therapy may reduce coronary heart disease risk by 50%, all-cause mortality. So again, timing matters, and that's why we kind of focus on that a little bit. But again, if you're out of that range, does that mean you can't take hormones? No, you just need to be evaluated by your practitioner. They need to go over the risks with you, the benefits with you, to take a look at your heart, see if it would benefit. Okay. The American Heart Association and Endocrine Society emphasize that hormone therapy should not be used for cardiovascular disease prevention at any age. Okay. And even though it can decrease that risk, we're not going to be giving hormones specifically for that reason. Okay, to decrease that cardiovascular disease prevention. Basically, what they're saying is that if you're using hormones for hot flashes, right? That's the main indication, that's the FDA indication. There are some benefits that you can get by using the hormones, but are we going to use the hormones to say that we're using it for cardiovascular disease protection? No. But will you get benefit? Yes, if it's used within that age range. Okay, so that's kind of the main point there. And let's see here. It says current guidelines support hormone therapy for the treatment of moderate to severe hot flashes in women aged 50 to 59 without contraindications. They recommend caution when initiating in women, so when starting hormones in women aged 60 to 69. And they advise not to use hormones in women 70 years or older, right? So, but individualized decision making and shared decision making are super, super important. And that's why you have to go to somebody that knows what they're talking about. Okay. So let's go over this. So summary of risk reality for people that are listening. So estrogen alone does not increase breast cancer risks, right? So some of the things that I want you to walk away from after having listened to this podcast are estrogen alone does not increase breast cancer risk. Combined therapy depends on progesterone type and timing, right? So there are different types of progesterones. There can be, some people use the progestin, like the IUD, right, along with the estradiol patch. Some people use a progesterone. Some people are using, if they are in perimenopause and they have this irregular bleeding, they can use a medication, drospirenone, along with 4 milligrams of drospirenone, along with estradiol patch, right? So there's different ways to do things, and you just need to go to somebody that knows how to give you all the options, right? And so now we're going to go ahead and move into formulations, delivery options, dosing strategy, and why pellets are not recommended. And then we're going to talk just a little bit about testosterone, when to use it, what the evidence says, and how Ishwish guides it, and why misinformation here also harms women, right? So now that we've talked a little bit about actual evidence, we can talk about how hormone therapy is delivered and why the way that we deliver hormones matters really, really tremendously, right? So, because there are so many different ways to get hormones, sometimes women get overwhelmed. Remember, there's the patch, the oral, the cream is for the vaginal estrogen, the gel, the spray, the progesterone pills, IUD, all this, right? There's so many different ways to get hormones. Systemic estrogen is used when we're treating the whole body. Okay, so we're going to talk a little bit about systemic hormones now. So when we're treating the whole body, when somebody says, listen, you know what, I'm having all this brain fog. And remember, the FDA indication is hot flashes and night sweats, but let's be real. You get more, there's tons of benefits to hormones. It's not just for hot flashes and night sweats, although that is the FDA indication and that's what the Menopause Society says. But we know that because menopause is a whole body event, and estrogen receptors are all over the body, that if you go and give estrogen, it's going to help with so many things, right? It's not just going to help with the hot flashes and night sweats, even though that's the only, and to prevent osteoporosis, those are the 2 FDA approved indications for hormones, but we know that it's going to help with so many other things. And so it's important to know that you can get hormones via transdermal, right? So anything that goes through the skin. So it's going to be patches, it's going to be gels, it's going to be sprays, it's going to be ring, or you can take it orally, right? But not everyone, based on what your medical history is able to take them through the mouth, right? Because if you have high blood pressure, if you're smoking, any of those things, you can uncontrolled high blood pressure, you definitely cannot take oral estrogen, because oral estrogen with uncontrolled blood pressure, we just don't give it, right? It can cause a stroke. So we don't do that. So, oftentimes, and I will say in my practice, and most individuals that want hormones will end up getting the transdermal, right? So it's something that goes through the skin, whether it is a patch, whether it's a gel, they'll end up getting something that goes through the skin. And because transdermal, and remember we talked a little bit about that, because transdermal bypasses the liver, and multiple reviews have showed, including the British Menopause Journal and JAMA, have discussed that transdermal estrogen, estradiol, is associated with a lower risk of blood clot than oral estrogen. Okay, so the route of administration, formulation type, significantly influence the risk profile. We know that observational studies have suggested that transdermal estrogen, something that goes through the skin, carries lower risk of blood clots, stroke, compared to oral formulations, right? And contemporary formulations use transdermal 17 beta estradiol at low to moderate doses with micronized progesterone. So that's typically the way that I will give hormones, is that I'll give the micronized progesterone and I will give something through the skin. And that are favored when somebody has, let's say, cardiometabolic or thrombotic risk that's present. And these regimens differ substantially, right? So these regimens, what we give now, are really different than the estrogen that was given in the WHI study, which was that conjugated equine estrogen and the medroxyprogesterone acetate. Some women end up using the combination of conjugated equine estrogen along with basodoxifene. And those women are, oftentimes those that cannot tolerate the progesterone, or don't want to take progesterone. So that's a medication that's an option for those women. Okay, progesterone and why that type matters, right? So, what type of progesterone should you take? Well, it just depends on what you're looking for, right? So, if you're a perimenopausal woman who's having hot flashes and night sweats, but you still need contraception, an IUD would be a fantastic form of progestin to take, along with a little bit of estrogen, right? The estradiol, because for perimenopausal women, we know that they are still able to become pregnant because they are still ovulating, right? So you're still ovulating. So you need some type of contraceptive method, unless your partner has a vasectomy or you've had a tubal ligation. But for a lot of women, they prefer the IUD, right? Because it's something they don't have to think about. And then they can just attach an estrogen patch to that. So we know that anyone that still has a uterus obviously does need endometrial protection or protection of the uterus. So they will need a progestogen, whatever that is. Micronized progesterone, which is oral, is not the same as the synthetic progestin. So that's important to know. Micronized progesterone, as supported by the Menopause Society and ACOG, has a more favorable breast safety and cardiovascular risk profile compared to synthetic medroxyprogesterone acetate. So that's really important. And of course, as we talked a little bit about the IUD, but there are definitely different forms of progestogens that you can use along with your estrogen. If you still have a uterus, you have to use some type of progestogen. Vaginal estrogen. So let's talk a little bit about that. So vaginal estrogen is local. It's not systemic. We know that there are tablets, there are suppositories, there's a cream, there's a ring. It's a gold standard. It's a first line of treatment for the gender urinary syndrome of menopause. We know that it helps prevent vaginal dryness, pain with sex, burning in the vulva, painful sex, UTIs. It prevents recurrent UTIs. Actually, you know what? I didn't even mention that before, but it's really, really important that you know that, vaginal estrogen prevents recurrent UTIs and it saves lives. So make sure that you are on vaginal estrogen, even if you decide to take nothing else. Let's talk about pellets. Pellets we don't recommend, and I'll tell you why. Pellets can sometimes give us supraphysiologic levels of hormones. And so we always want to avoid that. We don't want to give you hormones that can cause some type of side effects, right? Doses, and a lot of women will say that they're taking testosterone pellets, but those pellets can give you some side effects that are not reversible. I'll tell you what happened. I had a woman that saw my TikTok. And for those of you that don't know, I'm on social media, so I want you to follow me. My handle is at Dr. Sadaf OBGYN. I'm on Instagram, I'm on TikTok, I'm on YouTube at the Muslim Sex Podcast, and I'm also on YouTube as Dr. Sadaf OBGYN. But anyway, so I had a woman who saw a TikTok of mine and she reached out to me in my office and she said that she has been doing like testosterone drops, which I have no idea how she got them. She said she got them from like a friend and she'd been taking them. And now, like nobody had been following her. Okay. So she didn't get it from a medical provider. She got it from I don't know, from some friend. I'm not sure how they got it, but whatever. She'd been taking it. And so she went somewhere to get her blood work done and her testosterone was in the thousands. Okay. That is absolutely way too high. I mean, when we give testosterone, we make sure that we check your blood levels. We check them initially at 6 to 8 weeks, and we check them every 3 to 4 months. We want to make sure that the total testosterone level is within the reproductive aged woman's level, right, for testosterone. And let me tell you, 1,000 is way, way too high. And she noted that she was starting to get deepening of the voice. Her clitoris was starting to get bigger. She had acne. She was starting to go bald. So she had all of these like side effects of having too much testosterone. And now she wanted to know what she could do. And I was like, holy cow. Okay. So first and foremost, you need to stop that testosterone, right? And I told her of a friend of mine that is in North Carolina. I couldn't see her as a patient because I don't have a license in North Carolina. But, I told her of somebody that is currently there that works as a sex med doc. But, this is why this is really important, guys. If you are going to mess around with your hormones, right, and do something that is not FDA approved and you're thinking, well, I'm feeling great on this testosterone, my libido's great, But you got to have somebody that follows you. You got to have somebody that does your blood work, because you want to make sure that you don't get super high where now you're starting to get these side effects that are not reversible. Okay. So that's why that's really important. But okay, so that was about pellets. Let's talk a little bit about testosterone, since we already started talking about it. So now testosterone, we know that testosterone is made in a woman's body by the ovaries and the adrenal glands. We know that our body makes three hormones: estrogen, progesterone, testosterone. That's with the ovaries. And then once the ovaries stop functioning, right? So once we're not getting the estrogen, progesterone, testosterone from the ovaries, we still get a little bit of testosterone from the adrenal glands. Okay. So testosterone can be used, but for some women, they have super low testosterone. They also have super low desire. They have something called hypoactive sexual desire disorder. And we know that for women that have that, they can absolutely use, and this is supported by ACOG, ISHWISH, and the Endocrine Society, that women can use testosterone to help with their libido. Okay. And this is the thing though, we give only a tenth of the dose. So we are not doing these crazy levels. We monitor levels, we monitor side effects, we monitor, want to make sure that you're not having those, those crazy side effects, right? And remember, those side effects like that deepening of the voice, the clitoral these are non-reversible. Okay. So if that starts happening to you, we can't do anything about it. So really important that, you go see a provider that's going to be following you if you decide to go on testosterone. Okay. And because libido is, biopsychosocial, we know that testosterone is just a tool and not the entire treatment. So we need to, understand who is, a good candidate for testosterone, who's not a candidate. You want to get baseline labs and evaluation. You want to know duration. You want to know, whether or not you should stay on it, stop, whatever. For some women, it can take up to 5 months to feel a benefit after taking testosterone. Okay. So that's why that's really, really important. So now let's talk a little bit about who is the ideal candidate for hormones. Okay. And so the woman who benefits the most based on current evidence and guideline alignment is generally somebody that is within 10 years of menopause onset or less than the age of 60, has bothersome hot flashes and night sweats that affect the quality of life or daily functioning, somebody that has gender urinary syndrome of menopause, which, by the way, if you don't have it, you'll end up getting it. So really, I really think that hormones are for everyone. Does not have contraindications, wants to improve sleep that's disrupted by the hot flashes and night sweats, has bone risk factors, and wants to prevent osteoporosis, right? And we know that estrogen, one of the FDA indications is that it is approved to prevent osteoporosis. We know that those people who is not a candidate for hormones. Okay, so let's talk a little bit about that. So those that have a history of estrogen sensitive breast cancer, where oncologist does not support systemic therapy. Okay, now listen, is that a hard and fast rule? No, I mean, I know that there are women. I'll tell you, there's a patient that has an estrogen positive. She had DCIS. Okay, and it was estrogen receptor positive. She did not do tamoxifen. She did not do radiation. Now, am I advocating for that? No, you should absolutely do whatever your oncologist states, right? It's a shared decision making. You discuss it with your oncologist, whatever, right? So you have to understand what I'm saying is that there are women that suffer so much and their quality of life is just absolutely horrible after they've gone, experienced this menopause due to, let's say it was chemo, and she's a mess. And so we have to look at everything, right? We can't just be like robots and just be like, okay, so this one gets it, this one doesn't get it. You fall outside of that box. I can't give it. No, you have to take a look at the patient. You have to see how there's, are they suffering? Are they willing to take that risk? You want to have shared decision making. You want to be able to talk to their oncologist. You want to discuss it with them. You want to say like, hey, listen, this patient is really suffering. Is it okay? Is it not okay? If it's not okay, then I guess, they would have to see if there's other treatments available to them. But you really want to make sure that whatever you do, that there's some evidence behind it, right? That there's some science research behind it, and that it's shared decision making, and you want to make sure that you have all parties involved. If you have active liver disease, right, that could be a contraindication. Unexplained vaginal bleeding, of course. If you have unexplained vaginal bleeding, you want to make sure what the cause is for the vaginal bleeding before you start giving hormones, right? Active or history of VTE without ability to mitigate. So, again, these are it says that there are absolute contraindications, but I want you to go to your doctor and talk to them and see whether or not, you would be a candidate. Known coronary artery disease or stroke where risk benefit does not support therapy. Again, go talk to your doctor. Baseline evaluation. Okay, so of course we always get, before starting any type of hormones, we want to look at the medical history. We want to look at the surgical history. We want to see the timing for menopause. We want to look at the family history of breast, ovarian, uterine cancers, clotting disorders. We want to take a look at the blood pressure. We want to check the lipid profile. You want to discuss any risk tolerance and goals. You want to make sure, you want to see what it is that the patient really wants, right? And you want to talk to your doctor. If you're the patient, you want to talk to your doctor and tell them what your goals are. Duration of therapy. So now this is another huge myth, right? There's no mandatory stop date. There's no like, you must stop at 5 years or you must stop at age 60. That is not evidence-based. The Menopause Society, ACOG, and ISRISH all reinforce that duration should be individualized based on symptoms, patient preference, and risk profile, right? So you want to make sure that you go over all of that. Some women stay on long-term therapy because symptoms return when they're discontinued, right? Some women decide they want to taper off after several years. Some stay on low-dose regimens for bone health and quality of life. You just have to see what it is that you want, what your goals are, and, what your doctor, based on your risk factors, what is going to be the right management for you. Monitoring looks like, routine breast cancer screening, right? You definitely want to make sure that you're going for your mammograms. We know that women that have dense breasts, so this was at the Menopause Society conference I went to, women that have dense breasts are at an increased risk of breast cancer, right? But honestly, I will tell you that most of the mammogram reports that I get, every single woman has dense breasts. Like, I'm like, okay, way to cover yourself, but like every single person has dense breasts. So if that's the case, you can opt for a breast MRI, right? So in between, and based on what your risk score is for getting breast cancer, right? So you could get your mammogram and then 6 months, you get a breast MRI and make sure that you go for your clinical exams. You want to make sure that you get clinical follow-up and assess symptom control and side effects. And of course, if you are on testosterone, you want to make sure that you're going in for your blood work, right? You don't want to end up with hormone levels of 1,000, which honestly would be very difficult to get to if you are taking a tenth of the dose that a male takes, right? So it's your levels for that to get to 1,000, you definitely would have to be on pellets or you'd have to be doing something else. The decision framework that we use basically is that, what are your symptoms to decide whether or not if you should go on hormones, right? Like, what are your symptoms and how much are they impacting your quality of life? Are you within that window of hormone therapy where it would be most beneficial to you? But if you're not, right, it doesn't mean that you can't have them. You just need to have the shared decision making. Do you have any absolute contraindications? Do you understand the difference between systemic and local? And do you want to treat and improve quality of life and not just survive it, right? So although we know that women feel better because their physiology is supported, as evidenced by showing improvements of sleep quality, mood, and quality of life, that's associated with hot flashes and night sweats, we know that hormone therapy is not recommended for the primary or secondary prevention of cardiovascular disease. I mentioned that a little bit before, right? You want to make sure that you know that we don't give hormones to prevent heart disease, right? That's important. And also the U.S. Preventive Service Task Force recommends against hormone therapy for the prevention of chronic conditions in postmenopausal women. All right, so we're just going to talk just a little bit about, just going to zoom out a little bit because this conversation is definitely bigger than hormones by itself. We know that, this is about what women have been taught to expect from healthcare for 20 plus years, right? Women have been told to shrink themselves, suffer quietly, accept that misery is normal. And we know it doesn't have to be normal, right? Internalized fear around any type of intervention. We know that women were just told to oh, you're having these hot flashes, night sweats, that happens to everyone. It's okay. You just have to suffer through it. And what I want people to know from listening to this podcast is that you don't have to suffer. You have options. You need to go and learn about menopause, perimenopause. You need to figure out what your risk factors are. You want to see if hormones will be right for you and if it will improve your quality of life. And if it does, then ask yourself, is this something that you want to do, right? it's important to know that menopause is definitely not the end of you. It's a physiologic transition. It's definitely not a pathology. And we have decades of data now that tell us how to treat symptoms safely, effectively, and responsibly. So the problem was, the messaging, right? And as one of my friends says, menopause has the worst PR ever. So I think that it's really important for us to go back, take a look at the data and see whether or not hormones are right for you. And honestly, for most women, I truly believe that it is. So what you should take away from this episode. Okay, I know it was a super long episode, and women should take away from this episode. One, hormone therapy is the most effective treatment for hot flashes, night sweats, period, right? And this is based on data. This is from the Menopause Society 2022 statement. We know that vaginal estrogen for genitourinary syndrome of menopause is low risk. It's minimally absorbed. It dramatically improves sexual discomfort and pain and improves your bladder health, prevents recurrent UTIs. Okay, so remember that. So even if you don't do it, you're like, I have patients that tell me, oh, I'm not, or I gave up sex, as if they're giving up smoking, right? But like, I gave up sex once I hit menopause and I don't do that anymore. But no, it's not that. It's about maintaining your vulvar health, right? That's why this is so important. Maintain your vulvar health. Listen, you only have one body. This is not a dress rehearsal, right? This is it. This is all we got. So you have to make sure you take care of your body, take care of it. As my mom always says, if you don't take care of yourself, no one else is going to take care of you. Okay, so you got to take care of yourself. So vaginal estrogen is for the genitourinary syndrome of menopause. It's low risk. It's minimally absorbed. It dramatically improves sexual comfort and bladder health. Breast cancer risk, it has to be discussed individually, right? It's not, we can't say that, hormones are wrong for everyone. They're not. It's formulation dependent and universally not elevated. So you have to see what works for you. Transdermal estrogen is often preferred due to lowering blood clot risk, and testosterone therapy is evidence-based for hypoactive sexual desire disorder, right? But dosing must be physiologic per ISHWISH guidelines. Pellets absolutely are not recommended due to the supraphysiologic levels and irreversible risk and side effects that they can sometimes give individuals. Duration of therapy is individualized, and there's no one mandatory stop date. And remember, shared decision-making is the foundation. It's not fear-based decision-making. So you deserve individualized, evidence-based medicine and not one-size-fits-all fear messaging, okay? So that's why this is really, really important. And woo, that was a lot. So if you stuck with me and listened to the whole thing, I applaud you because it was a lot of information. Use this just kind of like learning, right? Just use it, just learn from it, get what you feel was important from here. The things that you felt were not important, you don't have to take back with you. It doesn't matter, right? I want you to be empowered. I want you to be educated, and I want you to make a knowledgeable decision for your own body and for yourself, right? I don't want it to be fear-based. I want you to decide if hormones are right for you and how you want to show up at your 90th birthday party, right? I have a mentor that always talks about her 90th birthday party, and I want you to think about your 90th birthday party, and I want you to decide how you want to be. Do you want to be strong? Do you want to be in a nursing home? What steps are you going to do today that your 90th self will thank you for, right? So think about that. Think about the decisions you make today and how they impact your life and what your future self will say, and will they thank you for it? So those are some thoughts I want to leave you with. And well, I am done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. This is just medical education, something that you can think about, listen to, and share with your friends. I want you to share it with your friends. I want you to share it with your colleagues. I want you to share it with everyone you know, because everyone needs to be informed about menopause, perimenopause, and the changes that happen, right? And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.